as a senior faculty for 5 or 6 years now, and I got into GI pathology after doing a fellowship at multiple different areas, including the University of Michigan at Brown, and eventually I circled around and had the pleasure of working with my friend and mentor, Vikram Deshpande, who is an outstanding pathologist and a wonderful mentor. So I got into GI pathology, and I loved it because it's a very organized field. It's very neat, and we get a lot of GI pathology, obviously. We have a lot of surveillance in the United States, and the guidelines in the United States are a little different than what we have in other parts of the world. So usually people come at the age of somewhere between the ages of 40 and 45 for routine colonoscopy. And, they obviously undergo various surveillance, mainly to look for polyps, to remove these pre-neoplastic or these precancerous lesions. And also, obviously to inspect for other reasons, of which it looks like you will be having a wonderful lecture of non-neoplastic GI coming up in a few sessions. So I'm sure they're going to delve into a lot of that. But what we're going to talk about and look into is really just, a couple of polyps where we can actually discover a lot of hidden things. So as I mentioned, we get a lot of these specimens, and then obviously subsequently we get a lot of resection specimens too, and partial colectomies or entire colectomies based off what we see on colonoscopy. So here is the first case. And just inspecting this at low power, we can see this isn't a biopsy, right? We can see, looking at the hierarchy of the tissue, we have an epithelial component. Can you all see my mouse?
Yes,
Yes.
Okay, perfect. We have an epithelial component. We have a submucosal component where we have our large vessels. That's how we know we're in the submucosa. And it's delineated from the mucosal surface by the muscularis mucosae. Then we have two layers of the muscularis propria. And then we don't really see too much here. When I zoom in, you might be able to see it. There's a little bit of connective tissue that delineates the wall of the colon from the outer adventitia. So when we look at this, just even at low power, we can see we have this pedunculated process, right? And pedunculated means it's not really flat, but it's protruding from the surface of the colon. And there's a lot of things we can actually gauge, even looking at this power, that's actually rather simple. One is this is the shoulder of the polyp. And this is helpful for a lot of reasons. When we're interrogating the shoulder of the polyp, we can see, even if we zoom in a little bit, we can see we have a nice orderly structure of colonic crypts. And, in America, we often describe this as having a test tube-like arrangement, in which here you see perfect hierarchy going from the surface to the base. And then, going back to low power, what I want to point out is the area that is lesional, if we actually look at the thickness, it's, it's a little subtle to gauge at first, but it is thicker the more you go towards the lesional process. And when we're thinking of polyps, they tend to have a proliferative molecular signal that leads to an expansion of the mucosal surface. And as such, that leads to the three-dimensional protrusion we're seeing at colonoscopy. So again, we're looking at this, and we have a very bland-looking colonic mucosa. Here it's cut on cross section, so some people say this looks like, when it's cut tangentially, it should look like I shouldn't say this, but a packet of cigarettes looking at directly into it, where you have these perfectly donut-shaped colonic crypts that are evenly spaced. And the lamina propria is comprised predominantly of a few inflammatory cells, but really just a lot of connective tissue cells. And you can have a little bit of inflammation, and that's fine. And also present, let's see, moving it around, is we have these little lymphoid aggregates that are present throughout the colonic mucosa too, and these are totally normal. These lymphoid aggregates are actually connected to the mucosal surface, and you can see right here even there is muscularis mucosa, and it actually gets disrupted by this lymphoid aggregate. And the reason for this is these lymphoid aggregates are actually communicating with the lumen of the gut, which is over here. And what it's responsible for doing is is that the surface or the epithelial component overlying these lymphoid aggregates, you actually have specialized cells, which are called M cells. And these M cells are responsible for shuffling in various antigens from the luminal bacteria that are the essential organisms that are present in all of our guts. And this allows maintaining an equilibrium in the gut. So in the West, where we have a very highly processed diet, we're finding, there's a lot of new studies that are showing dysregulation of, the pathology that we're even seeing in these particular areas. But you'll see these evenly spaced or almost evenly spaced lymphoid aggregates found throughout the gut, and that's very, very normal. And then this right here isn't a polyp, just to go over the slide. Because I think when we look at the slide, anyone who works with me knows I never look at the history until after I get an impression on the case, and that goes with any GI biopsy, any resection, any liver biopsy, including medical liver, because I always like to have a very unbiased appearance of what's going on, because then you pick up things that, if somebody told me this was a polyp, I'm going to look at the polyp, give the diagnosis, and I'm not going to look at the rest of the slide. I think when you look at it blindly, you have a more comprehensive understanding of what's going on. So this is just the normal undulations that we see within the colon itself. And this is, you have to remember too, in the colon, we have a lot of functions from just looking at the basic physiology of the colon. And I know the discussion of this is polyps, but I think we should have a little bit of fun understanding what's going on. So looking at this right here, we can see we have various cell types, right? So the pink cells here, a lot of them are actually going to be absorptive cells, because the colon, even though the small bowel does most of the absorption, particularly the first and second part of the duodenum do the bulk of our absorption, there's still a lot of nutrient absorption that goes on in the gut, including magnesium, zinc, and other forms of nutrients as well too. And so you see a lot of absorptive cells, particularly more proximally within the colon. Here we see a lot of these pink absorptive cells forming a brush border-like zone within these areas. And then interspersed, we see a few goblet cells. So looking at this and just seeing the background, we figure that we're probably more on the right side of the colon than on the left side of the colon. As you start going towards the left side of the colon, there's more of a decrescendo pattern or decreasing gradient of the number of absorptive cells you see. And there tends to be an increase in the number of goblet cells you see, because, at that point, the gut's job or the colon's job is, more of a lubricative function to help with defecation and stool and things of that sort. So just by looking at the background, we can figure, and not knowing anything about this case, we figure we're probably somewhere near the right colon. Definitely not the sigmoid rectum or descending colon. Definitely going to be more proximal to that, just given by the composition of the cells we're looking at. And also, you tend to see more lymphoid aggregates proximally, but you can actually see a whole lot of lymphoid aggregates in the rectum as well. Some people refer to these as rectal tonsils for our heme-inspired colleagues. But even then, just looking at that, we can see that, this is a nice thickness. It's not overly inflamed. The architecture is great. So whatever we're dealing with over here, it's not arising in an inflamed colon. It's actually arising in a background colon that looks otherwise very, very normal. And we can see it's not inflamed. We can see the submucosa looks intact, and everything looks very nice and well behaved. As we move along this particular segment of colon, what we can see is it's starting to, it's much more thin here, and it's starting to get a little more agitated. And here you're actually starting to see some what look like villus projections emanating from the surface, but it's not really neoplastic yet. And then as we keep moving on and on along this, we can see that, just again, focusing on the epithelium, there's a very sharp transition from here to here. Do you guys see that line? Where it's very blue and it's very not blue. And I always tell my residents that, a polyp, for the, in all intents purposes, most of the time these should be, something that you use your 2x or 4x objective on to make a delineation. It's always going to be very quick, because it's a pattern, and it's, unfortunately, compared to our to our colleagues who are in heme path or derm path who, or cytology who use, this is actually a better angle to look at it, who use the bigger objectives. Our job is a lot easier because, most of our work can be done using, 2x, 4x, and occasionally 10x. So looking at this right here again, see, it's a very sharp transition going from these normal colonic crypts to this blue stuff. So when we transition over to the blue stuff, we can see that we have this shoulder region of this blue stuff that seems to be relatively distinct from this pedunculated area that's emanating from the surface. And a sessile lesion would be more flat. Here you can actually see the submucosa leading up into this mucosal area. So when we start to interrogate some of these blue areas on the shoulder, what we can see is we have these cells. And again, let's go to an area where we have some normal here. So if we go a little bit higher, we can all appreciate that this is a normal colonic crypt, right? And here you can see these nuclei that have perfect polarization along the base. Here's a nice little apoptotic body, actually. So maybe this could even, yeah, it's not going to be neoplastic, but you tend to see apoptoses more in neoplastic things. There's actually a few papers on that, and I think it's somewhat of a contentious stuff because you can see apoptoses in a lot of settings. But here you have this very nicely oriented basal nuclei. All the nuclei are roughly about the same shape. And you can see that, they have perfect polarization. They're not stacking up on top of each other. And it appears at least that every nuclei is occupying its own space, and it's not really, using its shoulders to push aside, right? It seems to be very well behaved and very tame. As we go more north of this, we can see that, again, comparing to what's going on here, what instantly jumps up is how much bigger these nuclei are compared to what we're looking at over here. And then also what really jumps up as we go on to is, there's a lot more crowding, and we can see that the overall characteristics of the nuclei are more haphazard, and they're starting to stack up on each other, to the point where here you can actually, it seems as almost they're piling up on each other, and here's a little bit of acute inflammation associated with it. And again, here's maybe a little bit of normal right here. So when you go from here to here, it's a very night and day look. And really the diagnosis for what's happening at the shoulder of this lesion is all very self-explanatory by just being able to create this dichotomy where you have something very blue and something very not blue. So this in and of itself, and here's another really nice apoptosis here too that, some people say is a way you can distinguish it. So occasionally you'll have these lesions where you don't necessarily have this night and day look where you have normal next to abnormal because the background colon can be inflamed too. And some people say when you do have these apoptotic figures, that should lean you to calling it, the polyp, opposed to just saying it's all active changes. But anyway, so looking at this again at low power, because this should really be a low power diagnosis, this would be very good, be a very good adenoma. And some people call these tubular adenomas. People, don't use that disclaimer. Again, there's a lot of debate on what does it mean to be tubular, because an adenoma is an adenoma, whether it's tubular or tubular villus or whatnot. And really, it's the distinct adenomatous look, the blueness to it is what defines it. So I tend to call these adenomas, but I certainly have a number of colleagues who call these tubular adenomas, and that's fine. And that's because, and they're not calling it villus because this surface here is very rounded and it has a mound-like shape. Whereas if it was villus, it would look more like what you see in the small bowel. You'll have these finger-like projections, and, there is a school of thought that, and this would be something that, if this was blue, you could say, oh, is this a tubulovillus adenoma or a villus component? So there are those who argue that if you see a 20% villus component, or 15 to 25%, whatever it is, that you should give the disclaimer that it's villus. But there's a lot of issues around that. Mainly because, so people say if you have a villus component, that should confer to it a higher grade or a higher risk polyp. And by I mean from a higher risk polyp, it means essentially that it's more likely to have invasion associated with it, or, more likely to be associated with a metachronous or synchronous lesion somewhere else in the colon. The problems with calling something villus is when you actually start adjusting per the size of the polyp. So once a polyp really becomes, 1 centimeter or larger, or 10 millimeters or larger, that's really the main high risk feature. And when you look at a lot of these studies that do a multivariate analysis on these polyps, what they find is that once you actually start controlling for 1 centimeter, identifying stuff like, villus component or even high-grade dysplasia, it becomes somewhat of a moot point. It's really probably the size of the polyp that's driving its phenotype, not so much these other features, which have a lot of historical significance, but especially looking at, inner observer observations of what it means for something to be villus, or what it means for something to be high grade. They actually have very low inner observer kappa coefficients. And as a result, its overall meaning and its utility, it's somewhat moot. And really what drives the risk of most, if not all, polyps is going to be the size of the polyp. And this one, again, looking at low power, is well over 10 millimeters. And, this is 2 millimeters right now, so this is at least a centimeter in greatest dimension. But we still have to know what these are, because a lot of people still communicate and report high-grade dysplasia and villus component in their reports, and it's important to do so. So there's actually very good, and a lot of the issue too. So we'll go over high-grade dysplasia now too. So this is an adenoma, and oops, I don't want to get to that part yet. That's the last part we're going to talk about on this particular slide. So what does it mean to be high grade? Again, I think it's not as critical as it was maybe 10 or 15 years ago to comment on high grade dysplasia. I certainly do it at times where I'm concerned about cancer, but I don't quite have a cancerous component. So that will be the situation in which I tend to mention high grade dysplasia. If it's an adenoma and I think there might be a focal high grade component, I honestly, most of the time, I don't mention it anymore, and because I don't think it's important. I think the endoscopic size, and again, identifying it as being an adenoma, are going to drive the surveillance in America in terms of how the patients followed up. But everyone is a little different. And everyone's going to do it a little differently. But here right now in front of you is so if you look here, this is probably more of a low-grade component where you have a donut-shaped area again, and it's really occupying its own space. The nuclei are rounded, which is a little abnormal for low grade. They tend to be a little more pencilate and skinny, but I don't really have that component in this area of this particular polyp. But they can be rounded too. And what's really helpful here is you can see that the nuclei are maintaining its polarity. And for me, when I do assign dysplasia, polarity is really the most important thing and the most important attribute that I look at. So when my nuclei are lined in a perfect row, and they're not really piling up on each other, for me, that's really good low grade. And you can get a little bit of pseudostratification where they give this appearance that they're piling up. They're actually not piling up because it's more of a product of how the nuclei are crowding in that area. Whereas when you actually have true loss of polarity, your nuclei start taking on different shapes, and they start flipping around, and they start doing all these crazy things, which you're going to see momentarily. Architecture can also be helpful. As I mentioned here you have a nice donut-shaped crypt, and here you have a few more. And then as you start progressing towards some areas like here, you can see that it's very hard to start drawing a circle around some of these areas where you have this interanastomosis of all of these crypts with each other. And you can see that this is starting to get accompanied by a higher grade phenotype, where if you actually start looking at the nuclei, you're actually starting to see here it's actually even sheeting. And once you have this is, no one would ever argue that this isn't high grade. Or even something else that's potentially growing upwards, but we'll talk about that in a second. But here you can actually see a complete loss and disorganization of the nuclei. They're piling up on each other, and even these little lumens that would have formed and start interanastomosing here are starting to be solid sheets. And you can even see emanating off the edge of these are even probably some single cells that are infiltrating into the lamina propria. Some people refer to this as being something called intramucosal adenocarcinoma, but again, that's a term in the colon which is highly contentious. So the reason why it's somewhat highly contentious is that it's not really well documented that if you have single cell invasion in the lamina propria, that those have metastatic potential. So if you excise it and you do a polypectomy or you do an excision to remove the polyp and the patient's cured, should you really be calling it cancer if it has no risk of metastasis and it has no risk of local recurrence? And I think that is a big debate where, some of my colleagues, well, honestly, even if you had all of this right here with the high-grade component and no invasive component, they would just call it an adenoma, and they wouldn't mention a villus component, they wouldn't mention a high-grade component, they wouldn't even mention an intramucosal, an obvious intramucosal cancer. There are people who will just call this adenoma, and, for all intents purposes, it's going to be followed up and undergo the same surveillance as a polyp that does have those high-risk features. And I guess what's important to mention is that, even though these colleagues of mine, including sometimes myself, don't mention these features, they are actually still important. So an adenoma in and of itself is the first step of progression of, a person to developing colon cancer. And this is usually through a gene mutation in a gene complex called the APC attack membrane complex, and also in a gene that codes for beta-catenin. And as these polyps progress, they start developing additional alterations. And this is actually a pathway of colon cancer called the chromosomal instability pathway, where they start accumulating these additional mutations such that those additional mutations probably correspond to high-grade dysplasia, and then intramucosal cancer, and then invasive cancer. And so that's why it's actually very beautiful in terms of how neat and organized it is. If you think about other organ systems, the most common pathways of colon cancer of other cancers don't have that beautiful stepwise progression where you can identify the morphology and the molecular alteration as having this very almost thoughtful process or evolution in terms of how it behaves or interacts. So moving on this, unless anyone has any questions, because I like this to be interactive, so feel free to ask any questions before we move on. Otherwise, I'm just going to keep talking because I can talk about this stuff forever. But unless anyone has any other questions, we'll move to the other part of this polyp.
Sir, sorry to interrupt you. There are few questions in the chat box. Can I ask?
Absolutely.
Oh, sir, question is, how do we differentiate if it is a mucosal folding or a polyp?
A mucosal polyp. It's a great question. So again, looking at this, oops. So this is the mucosa, right? The mucosa is the epithelium that's confined to the mucosa. So it's your epithelial lining, it's your lamina propria, and it goes all the way up through your muscularis mucosa. So anything that is appearing and emanating above this line here is considered a mucosal polyp. And then anything then obviously that occurs in other layers of your gut wall, which we definitely see. We see neuroendocrine tumors in terms of an epithelial tumor. And then we can see a whole array of different soft tissue tumors that can occur in other layers of the gut that can involve the mucosa. But this is definitely a mucosal polyp because we can see that the epicenter of this lesion lies within the mucosa, right? And then everything else, even beneath what we're seeing here in this shoulder region, is entirely normal. So we know this is a mucosal polyp.
Okay. Sir, second one is, why do we call the nuclei pseudostratified in adenomas and not just stratified?
Yeah, it's because they're so. If you were to actually, let me see if I can find a nice area that's pseudostratified. Of course, I picked the one polyp that doesn't have the most classic pseudostratified. There's a little bit right here. I'm going to zoom in on it. Look at that apoptotic debris in that crypt. So these nuclei that are actually piling up here, they still have their polarity and they're still oriented, right? So this is a low grade crypt. And when you see this level of pseudostratification, this is a byproduct of these cells that are starting to crowd up in a very small space. But each of these nuclei actually have an association still with the basement membrane. It's just sort of it's the angle of which you're looking at it and the way in which the tissue is cut. Um, and then you can see these beautiful, more pencilate nuclei here. But then as you go to a higher grade, see how this nuclei over here is turned on its side and it's lost that natural orientation and architecture with its base. So here you can see the nuclei lining nicely against the base. Here you can see this nuclei is flipped on its side, and if we go to other areas that are more conspicuously high grade, let me go to lower power to go to a more conspicuous area. Oh, this is good low grade here. Let me go zoom in on this area. See this? This piling is what pseudostratification is. But you can still see that if you look at the cell in terms of how it's oriented, all of them still have this perpendicular association to the base, and that's proper pseudostratification. It's once when you start getting the twisting and enlarging of the nuclei and stuff turning on its side like I showed earlier, that is when something starts becoming high grade and tends to be a more advanced lesion.
Okay,
Go
sir.
back to that
Is
area here just to show you what I mean when I say that. Any other questions in the meantime?
Yes, sir. Is there tumor tissue in the lymphoid follicle in submucosa?
Yeah, well, we're going to go to that. That's going to be the next part of this polyp that's
Okay.
misbehaving. Um, oops. Yeah. You see how these nuclei look very haphazard and ill-oriented? This has to be high grade just because everything is just too messy and it has no order or no structure to it. The nuclei are doing whatever they want. And for me, again, it's really losing that polarity, which is really the defining feature of a more advanced dysplasia within polyps. So now we're going to move to what else we see. But again, we're going to move to low power first because this is what we expect how we should be evaluating these polyps. Any other questions before
No,
we
sir.
go into the next part?
No, sir, that's all.
Okay, excellent. So then looking again at the polyp at very, very low power, we can again see, as someone mentioned about the lymphoid aggregate, we have lymphoid aggregate here, and you can see they're really not too big. Here, this is a really big looking lymphoid aggregate, and this is a much bigger lymphoid looking aggregate than what we're seeing in the background. So that in and of itself doesn't necessarily mean anything because you can have activated follicles in your colon, and that doesn't mean too much, but it does cause us pause to look at it a little differently. The other thing I want to draw our attention to is, again, we said that polyps should be confined to the mucosa. So when we're drawing a straight line, so this is our muscularis mucosa, and we're drawing a straight line, and remember, lymphoid aggregates can disrupt the muscularis mucosa, and that's okay. And if we go from this side, we're doing this. We run into a point where all of a sudden, drawing a line, as I showed you on both sides, doesn't become obvious anymore. And when you start having that occur, it's going to be in a polyp, one of two phenomenons. Occasionally, especially in pedunculated polyps like this, you can get prolapse. And prolapse essentially causes you have to remember the polyps are three-dimensional, right? So when you have a narrowing of the real estate that you're working with, it causes the normal structures to splay apart and lead to, things looking maybe a little bit more disorganized and in areas they're not supposed to be. But even then, you still have obvious lobular contours and you have, other features too, like, bleeding because again, it's prolapsing on itself and it's going to be a little more ischemic on itself when that happens too. And you're going to see, you can maybe see extravasated mucin and everything else. So this one at low power, it doesn't necessarily look like prolapse, but maybe at low power we can't entirely rule it out yet. Um, but again, we do see a lot of these normal structures going beneath where they're supposed to be. So then that raises cancer in the differential. And there's only two ways in a polyp, or in colon cancer, really in general, in which you can define cancer. And it has to have at least one of these two features. And in pedunculated polyps, this can be extremely hard because of the prolapse of the normal structures. But the two features of which you need to see in order to call something cancer is one, you either have to see tumor at the level of a large vessel like this, right? Because you don't have any large vessels in the mucosa. And that's probably why, no one's ever described intramucosal cancer. You do have lymphatics, but again, as I said, no one's ever really properly described metastasis of an intramucosal cancer other than, case reports of signet ring carcinomas that are confined to the mucosa. And I think it's even in those situations probably somewhat debatable of whether the authors leveled enough through it, but I digress. Um, oh shoot, what happened? Okay. And then the other thing that you need to see in order to call something cancer is stromal desmoplasia. When a tumor, and this is really any part of the gut, whether in the stomach or small bowel or the G junction, or the esophagus, when you have invasion in the lamina propria, you're not going to usually get a stromal response. Stromal response really only occurs in the microenvironment of the tumor when you breach the muscularis mucosa and you invade the submucosa. And that's probably because that microenvironment there, um, isn't used to having that epithelial component, and that sort of dysregulation leads to something called cancer-associated fibroblasts, and you get this fibrotic response to the tumor such that you get fibroblasts that are intimately associated with your cancer glands. And that's what proper desmoplasia is. So now we're going to try and see if we can find any of those features when we're looking at it at higher power. So here we have a larger vessel, and maybe this could be other areas of hemorrhage of the polyp because, again, it's probably bleeding a little bit too. But we're starting to see tumor at the level of large vessels. But again, this is prolapsing, so that's not as reliable a factor. This might be a large vessel over here too. And then what we really want to see is, do we see an obvious stromal component? And this is actually a very, very interesting polyp. And I wanted to show this because I think it highlights a lot of principles of what we're going to look for. So when we're looking at this, we're seeing a lot of things. We're seeing this mucin pool extrude to the point where you even have a giant cell reaction and a histoacidic reaction to this mucin, which can happen. You can see this in normal polyps too. But what's really interesting in these areas is you're starting to see this stromal response. And these look like even some of these glands up here, right? But when you start looking down here, the qualitative, so if you get a picture of what the lamina propria is supposed to look like. So we'll look at the lamina propria really quickly. So this is what your lamina propria is supposed to look like, right? You're supposed to have these, scattered inflammatory cells, maybe a few eosinophils. Here's a neutrophil. Then you have a couple of these stromal cells, but the stromal cells are somewhat haphazardly oriented. They're not really affiliated with your glands or anything like that. Here's probably another one that's reactive because of, the adenoma and everything else, but there's not really this orchestrated phenomenon of a stromal response. As we start moving deeper and deeper into the process that we're looking at, here again, we're only seeing stuff that looks like lamina propria where this mucin pool is. And occasionally you can have cancers that don't have a stromal response too. But as you start moving further and further down, where we were originally, you can see more of this concerted effort where you're starting to get these fibroblasts aligned somewhat against these crypts. And you're starting to see this stromal response around some of these larger glands where that's pathognomonic for an invasive cancer in the gut. And, even when you have a crypt rupture, you can have somewhat of a response here, but it won't produce and the organized look that you would expect to see in desmoplasia. And desmoplasia can take on many shapes and forms. It can be mixoidy, it can be more collagenous. And we're going to show you other areas of here too where this has to be cancer. And there's really no way around it. But what's really interesting about this polyp, where here you have this more adenoma like adenocarcinoma here, right, where you couldn't really differentiate it from what was going on below. You have these other areas where you have more rich mucin pools, where here you have these mucin pools. Again, here you have some giant cells at the edge, and you're starting to wonder, could this be somewhat of a mucinous phenotype? And uh, you had a floating cluster of cells, and here's some really nice desmoplasia that's going on right here, where you actually have these fibroblasts starting to arrange around these glands, and your eyes will get used to it the more you look at it. Um, and what was really interesting about this, though, is here you have a morphology of the cancer that looks more cribriform, right? You have these glands that are fused together rather than adenoma-like. So you have a mucinous cancer morphology. You have an adenoma-like adenocarcinoma morphology. Here you have more of a cribriform-like morphology, which actually used to be a WHO variant as a high-risk colon cancer feature. And then as you start moving around this particular component, you start seeing other morphologies, right? You have these cells, again, floating in mucin. And if you interrogate these cells a little higher, you can see that they have this signet ring quality, where you have these mucinous cells that are, again, locked in together. The nuclei is everted to one edge of the cell like a signet ring. And here you can even see all these other signet rings that aren't in mucin pools that are, again, starting to form sheets within this area of the submucosa. And then to the wonderful comment of, is there cancer involving the lymphoid aggregate? The answer is yes. There is a couple of different areas within this lymphoid aggregate that do have cancer. Here's one of them right here, where it's starting to form more of this nested solid sheet within this lymphoid aggregate. And then as we go even further here, look at how subtle this is. So this is actually even associated with a lot of lymphocytes, where it's almost imperceptible from the surrounding background. If this is all you had, I would probably still get a keratin just to confirm that this was cancer, even though I know it's cancer. But this is another type of morphology that we're seeing in this polyp, which some people refer to as medullary carcinoma. But medullary carcinoma in and of itself has very distinct criteria in the WHO, of which one of them is mismatch repair, in which basically most of the time they're mismatch repair deficient. But the reason why I wanted to highlight this particular polyp is that it had a lot of different things within it, right? You had these adenoma, you had high-grade dysplasia, you had areas of an intramucosal component, and then you saw an evolution of this polyp into all these various morphologies, where you had stuff that looked more like conventional adenocarcinoma, that looked like these glands, to these areas that looked more mucinousy with floating cells and signet ring cells, and areas that looked more cribriform, and then here areas that looked more medullary. And if you look across these cancers, as they start becoming more invasive, they actually also start becoming molecularly a lot more heterogeneous. And as a result, you can see a diversity of phenotypes in an invasive component, and you tend to see this more in cases that are deficient in mismatch repair. So, just out of curiosity, how frequently do you always order mismatch repair markers on your invasive colon cancers, where you all practice, or MSI testing? Hello?
Students,
I wasn't sure if I disconnected. I was really nervous there for a second.
Ria, Trey can respond.
I see someone wrote yes. So maybe that is MMR as a reflex. Perfect. Yeah, I'm seeing some of the comments now. Okay, that's really helpful. So I'll go back to this. So yeah, so this is really helpful, and you tend to see this diversity in cases that are deficient in mismatch repair because, mismatch repair is essentially they are proteins that help correct base pair mistakes within DNA replication. So when you have a mutation within that complex, that leads to a higher mutation rate within your colon cancers, and as a result, they tend to show a lot more morphologic diversity because the molecular profile, while the driving mutations like beta catenin or KRAS, and like you wouldn't see that in deficient mismatch repair, you would see a BRAF mutation though. While the BRAF mutation will be the same, and the mutation in the MMR gene will be the same as well. All the other genes that wind up getting mutated or the chromosomal alterations that wind up occurring within these particular areas of the colon cancer can be vastly different from one area to another area. And these tumors tend to be, they tend to show morphologies like this medullary morphology because these tumors, because they are making a lot of mistakes while they're replicating, they're producing a lot more tumor antigens. And as a result, your immune system recognizes these tumor antigens, and your cytotoxic T cells or your CD8 cells and even your NK cells can respond to these tumors and help you control the progression of these tumors, which is why these tumors tend to have a better prognosis because your immune system is more robust in attacking these tumors, whereas conventional colon cancers are mutagenically very much more attenuated. So your immune system isn't as strong in regulating the progression and behavior of the particular cancer. And that's why checkpoint inhibitors that help further augment the response of the immune system is very, very helpful. Any questions on this particular case? And then I'll try and show one serrated polyp really quick too, so that you guys can see that as well. I think I lost track of time as I was presenting this. My apologies.
Sir, there is no question, sir, in the chat.
Okay, so let me go to the amazing serrated polyp I have here. Very amazing case. Oh, this is a very cool colon cancer, which I don't have time to share, but I will show you guys that. This was on a series that I published with Vikram on something that we coined lymphoglandular complex light carcinoma, which is going to be in the new WHO, which was very interesting. But we're going to focus on this one. So let me open this. Let me see. So here is, how do I get rid of this? Okay, here we go. So here is, again, looking at this, this is two different profiles of this polyp, and they both scanned. So what we can see here, opposed to the last polyp we looked at, this isn't pedunculated, right? This is more sessile. It's flat. But again, we should approach this the exact same way we approached the other one. Namely, we should see this is just an endoscopic procedure. So in this one, we're not going to see the muscularis propria or anything really beyond the superficial submucosa or the superficial few layers of the submucosa. But anywho, looking at this again, we can see the submucosa is, there's some fat. So, you can see a lot of fat, particularly as you get towards the cecum or ileocecal valve. And you can sometimes see it more distally too. It doesn't mean you have a lipoma, but you can just have fat-rich areas. And I think lipomas are drastically overcalled in these areas. But again, interrogating this particular case the same way in which we interrogated the other case, we can come to the solution really easily by just following a very methodical and pragmatic approach. So going to the edge of this particular polyp here, which we see is inked because our physician assistants love to ink stuff. I'm not a big fan of ink, but it's part of our protocol, so we have to do it. So again, here we have what looks like normal colonic mucosa at the edge. And as we're going towards the area, we're starting to see this area is getting, again, thickened, right? Can you appreciate how this area is thicker than this area? It's actually at least 2 times the thickness of this. And it can be subtle when you're looking at it. But again, this is where your lesional process is occurring. And when we start going more towards the center, we can start seeing at low power these slit-like serrations that are emanating from the surface of the polyp to the base of the polyp, such that, some people describe these as looking like an anchor that's coming off a boat. Some people say they look like the feet of ducks. But again, they have these areas that are delving down. And what's actually happening in this particular polyp is, so the normal proliferative zone, or the normal area where your regeneration in your gut recurs, and regeneration and turnover in your gut occurs about every 4 to 6 days or so. That occurs in this area here, which has your stem cells, your Panna cells, and your progenitor cells. And what happens in this particular polyp is that, it is a little asymmetric appearing. And what happens is your proliferative zone actually gets flipped on its side, like over here or maybe even over here, such that it's no longer along the base. So it's proliferating in in somewhat of a disjointed way, where it's growing up like this, and it's growing in this direction and eventually this way. And what's ultimately happening is, when we compare it to the last case that we looked at, the cells here look mature. They don't look dysplastic, but rather you're getting a lot of these cells, right? Where you're getting these tufts that are appearing within these crypts, and you're getting these almost even like pseudopapilla type areas within these crypts too, where you're getting a piling of cells, because none of them are really desquamating. They're staying attached, and it's leading to this hyperproliferative look. And that's leading to these serrations that we're seeing. It's this proliferation of these cells that's occurring, of these normal appearing cells. And that's really the hallmark feature of this particular polyp. And here again, we can see these serrations going from the surface all the way to the base. So if you guys had to take a guess in terms of what type of polyp this is, what would you guess?
So sessile serrated lesion.
Yeah, sessile serrated lesion. And, that obviously went through different nomenclature through the years. It was at one point called sessile serrated adenoma, sessile serrated polyp. And I think the new WHO is going to maintain this language. So we'll see. But what's really curious about this polyp isn't so much the sessile serrated lesion, it's this other stuff that we're starting to see. So again, like most pathology, what's very interesting and very helpful is that whenever you have relevant pathology, the transition is never really in colon pathology gradual. It's usually very sharp. And here we have such a transition again where, albeit this one's maybe more subtle than what we saw with the adenoma, we have something that's sharp. So what do you guys think about this particular area here, getting you involved a little bit more? So on the shoulder, we do see a sessile serrated lesion. And now we're seeing something like this. So what do you think's going on here? Any guesses?
Some horizontal boot-shaped gland dilatation, sir.
There is some at the bottom, but that's part of this entity, and it's a very curious entity in terms of what's going on here. Any guesses or any speculations in terms of what this proliferative process might be associated with this lesion? So this is actually a traditional serrated adenoma arising out of a sessile serrated adenoma, or a sessile serrated lesion, or a TSA. So what are the hallmarks of a traditional serrated adenoma? Do you guys know? I talked a lot, so I'm trying to get you guys involved a little bit. Well, I'll tell you guys then. So we have, again, we have to have slit-like serrations, which we have, check. The other thing which we tend to see, and this is, again, this comes more down to the nuclear features. Well, actually, a few more things we see. One was at low power. So they tend to have more of a projectile look. So they can be villous, they can be this more rounded shape, they can be an interanastomosis of villi, and they can have this shape of something that's not flat. SSLs should be flat, right? They shouldn't have this protrusion from that. This is a different biologic process what's going on here. So when we look at this, we saw the protrusions, we saw the slit-like serrations, and then what do you guys think about the nuclei here? What do they kind of remind you of? in terms of them piling up like this and everything else. Look at this. Look at this piling here. You shouldn't really see this in an SSL, right? You can see it occasionally at the surface when it's reactive and you can see that the loss of mucin and stuff, but this is different. This is, you can even see a goblet cell here associated with it. This is biologic what's going on. And the nuclei here are a little more pencilate and a little more elongated, and they don't quite look like what we're seeing, like say over here where they're a little more rounded and polarized to the base. So here you have a piling up of these nuclei, and then the last thing you see in these is this little phenomenon that I'm circling right here, and I'm circling right here, and you can even see a little bit right here and right here. These are called ectopic crypt formation. And ectopic crypts are another defining feature of this. What an ectopic crypt actually is, and people have done molecular studies on these, is that they actually have progenitor cells, not stem cells, but they have progenitor cells within these ectopic crypts. And that allows probably for part of the growth pattern that we see in this particular entity. So this is a traditional serrated adenoma arising out of a sessile serrated adenoma. And we know that this isn't just a TSA by itself, because a TSA is considered a higher grade lesion, and it's considered to be a form of dysplasia within an SSA. So it is a higher risk lesion. In America, this automatically buys you a colonoscopy every 1 to 3 years, whereas one SSL will be somewhere between 5 to 10 years. So this in and of itself will buy you an additional colonoscopy. But again, these are bigger than 1 centimeter. And usually when you have a polyp that's bigger than 1 centimeter, whether it's serrated or an adenoma, that's going to buy you a colonoscopy in 3 years too. So this is maybe a little more educational, what I'm saying, and maybe doesn't have that many practical implications. But what's essentially happening here is that you have this SSL, and these can happen in the right colon and in the left colon. In the past, historically, it was always assumed that SSLs have to, TSAs, or traditional serrated adenomas have to occur in your rectum or your rectus sigmoid area, and that's actually not true. There's probably 2 different types of traditional serrated adenomas that can arise, and one form of traditional serrated adenoma can arise is out of sessile serrated lesions. I often say sessile serrated adenomas because our clinicians still want us using that nomenclature for some reason. They're not comfortable with SSLs. Regardless, so SSLs almost invariably have a BRAF mutation. Not always, but almost always. And what happens in a subset of SSLs is, they can progress along various pathways of serrated neoplasia. I think the pathway that we're most comfortable thinking about is, these develop a mutation in MLH1, which is part of the mismatch repair deficient pathway, and these become mutation high tumors along the microsatellite instability pathway, or the CIMP pathway too, because it's more like a methylation pathway. And what's happening here is these are the same BRAF mutated cases, but instead of developing a mismatch repair deficient gene, these actually develop a mutation in something called RNF43, or there's other gene fusions that are associated with this as well. And these actually progress along a entirely different serrated pathway of neoplasia. And these colon cancers actually are very, very aggressive when they become malignant. And these are the ones that frequently present with liver metastases, and these are the ones that often have a very poor outcome and survival associated with it. Is recognizing this really, really important? Probably not super important, because like I said, drive is always going to drive surveillance. But I think it's interesting to understand, and I think it's important to point out all these different areas. Here's a little bit more of this TSA-like phenotype here. Again, it looks pinker than what you would see in an SSA. Look at how mucinousy this looks. This looks a lot more pinker. And you have these more slit-like serrations within this area. And you can see these boot-shaped crypts at the bottom. And that's just because this is arising out of an SSA, which is very cool. You don't see this all the time. And there can be other forms of dysplasia within SSAs, something called minimal deviation. I'll go to that on the slide thing. Oh man, where is it? I just show you a couple of those slides too before we wrap up. So there's a few other morphologies you can be familiar with. So there is something called minimal deviation, and in minimal deviation, essentially it's very subtle. You see this very prominent glandular crowding in SSAs, and um and you can see some, like, nuclear disturbances. I stole this from a paper, but this is helpful in that if you were to do an MLH1 on this, you'll see the loss, so that will be how you diagnose dysplasia. The other forms of dysplasia, fortunately, morphologically, are very conspicuous, but the MLH1 is not helpful because they progress along a different molecular pathway. So this next one is, these are my pictures, a serrated form of dysplasia, where you can see that these nuclei here, when you're going from this area of the serrated polyp to this area, that the cells are very pink, but they have these very large rounded nuclei with prominent nucleoli, almost melanoma-like nucleoli, that are present within here, so they can be very, very obvious, again, morphologically, even though the MLH1 won't be helpful. So here you can see the serrated portion, and then here you see the dysplastic portion associated with it. But it's very obvious, as you can see, going from here to here, how they're very, very different. And then lastly, the other type of dysplasia you can see is the adenomatous type dysplasia. And this just basically looks like a tubular adenoma combined with an SSL, where you have a very obvious adenomatous component like we have right here. Again, your adenomatous cells are at the surface, and you always have to have an adenomatous component at the surface to call it an adenoma. And then you have an obvious serrated part too. So this would be an adenomatous type dysplastic area. Again, it has to involve the surface, arising out of an SSL. And one more thing I forgot to point out about adenomas too is adenomas don't have to be full thickness, but they have to arise, involve the surface. And the main reason is that the initial alterations that occur in adenomas are more mid-zonal, and they don't necessarily always distribute to the surface and the base equally. They usually hit the surface, and then eventually it becomes full thickness and involves the whole thickness of the colon, which is why occasionally you see normally looking crypts mixed in with adenomas. So I think I've spoken for an hour, and I should probably stop there, but I wanted to have time to answer any questions, and I'm really hoping I was interesting and didn't bore you.
Sir, yes, there are a few questions, sir. Can I ask?
Sure.
Sir, one question is, can tubular or tubulovillous adenomas have focal serrated architecture? If yes, what do we call them? Adenomas with focal serrated architecture or sessile serrated lesions?
Yes, that's a great question. So there is a group out of Australia headed by Mark Beddington, a brilliant pathologist. So they do a lot of work in traditional serrated adenomas, and traditional serrated adenomas can progress and show a higher grade dysplasia as well. What's really interesting though is you can also have a subset of adenomas, which our friends in Australia have coined them as being so-called serrated adenomas, because they're molecularly identical to what you see in a tubular adenoma, and for all intents purposes, they're followed up and considered exactly the same. The difference, the qualitative difference is that in adenomas, you never really see slit-like serrations. But you have to be careful when you look in an adenoma and you see serrations. Unless you actually see at the shoulder of the polyp serrations, you shouldn't really be calling it a serrated adenoma. Because you remember, these polyps are three-dimensional, and they twist and they turn and they dilate, and they have all these weird things happen to them. So, if you see an occasional serration in an adenoma, but the shoulder and what's bridging the polyp look normal, just call it an adenoma, because that's what it probably is. And again, it probably won't change management too much, but that's probably what's going on.
Sir, next question is, how do we grade dysplasia in serrated lesions? What is the difference between serrated dysplasia versus adenomatous dysplasia in serrated lesions?
Yeah, and minimal deviation dysplasia. So the truth of the matter is we actually don't grade dysplasia in serrated polyps. And that's, per recommendations of the WHO as well, and in pretty much every grading manual and authority committee on this. And again, a lot of that stems from inter-observer variability and things of that sort. And the other thing is that, at the end of the day, so long as you're removing the serrated polyp, whether it's dysplastic or not, it's really not going to change the management or the surveillance of the patient. So, you could imagine where you have a case where somebody's calling something a traditional serrated adenoma arising out of a sessile serrated lesion, or someone saying adenomatous dysplasia, or somebody saying this or that. And ultimately, it doesn't matter. And there's going to be so much inter-observer difference in terms of how people interpret it. That being said, when I do see that minimal deviation type, I usually get an MLH1. And even if the polyps, because occasionally you'll get a biopsy of a polyp because it wasn't amenable to a polypectomy or an endoscopic mucosal resection where they'll have to actually go and excise it. And the time it takes so serrated polyps, sessile serrated lesions, they have a longer latency to cancer than a typical adenoma. So, but once those polyps actually show loss of MLH1, most of those, if left untouched, would probably progress to cancer within a year, which is much, much faster than what you would expect to see in a typical adenoma, which is going to be probably somewhere between, 7 to 10 years or so, which is why we have our surveillance guidelines to catch those interval things. So those patients will probably undergo more rigorous surveillance, but at the end of the day, is differentiating them important? Probably not. We certainly don't do it.
Okay. So next question is, WHO says sessile serrated lesion is mostly seen in right side colon. Can I diagnose sessile serrated lesion in left-sided colon?
Yeah, absolutely. You can definitely do it. We do it all the time. Vikram even diagnoses them in the rectum, which I rarely do, but because I think a lot of prolapse is going on in the rectum, which is causing it to look like SSL. The reality is, in America now, our guidelines too, really even differentiating between a hyperplastic polyp and an SSL isn't as important, because they're actually going off now whether it's serrated and what the endoscopic size is, because it becomes very trivial and arbitrary at points. And if you look at the definition in the same WHO, they say so long as you have one dilated crypt at the base of the mucosa, you can call it an SSL. So there's no reason why I should hold back in calling. I call SSLs in the left colon daily, multiple times.
So next question is, how do we differentiate invasion in adenomas from pseudo-invasion? What morphological features favor pseudo-invasion?
So pseudo-invasion, fortunately, it's unfortunately, it's very wicked, and sometimes we have to show a number of our colleagues because we're not sure. Fortunately, there are certain things that can be associated with pseudo-invasion which are very helpful. One, when you see, well, and the other thing I have to point out is just because you have pseudo-invasion doesn't mean you can't have invasion in a pseudo-invasive polyp, right? So there's a couple things you can do. Pseudo-invasion, fortunately, is going to be oftentimes have a very nice lobular contour, which is going to do that. As one of the comments said, it's going to carry lamina propria with it as well. But sometimes you don't have that, and it can be wickedly deceptive and tricky, especially when you have some glands rupturing and extruding mucin. Getting levels is obviously very helpful. So if you see those glands obviously meeting up with the surface and starting to develop, again, more lobular contours on deeper levels, that's helpful. Looking at the architecture in and of that area. So if you have a higher grade morphology deeper within the crypts and you're worried about invasion, that's probably an area you want to level as well too. And then obviously lastly, looking for single cells and such, and looking for a true desmoplastic response can be very helpful.
So next question is, what there's difference between upper GI and lower GI PT1A carcinoma high-grade dysplasia?
So upper matters. It matters to a point. So in the esophagus, in the setting of Barrett's, again, I'm speaking only in terms of how these are treated at where we practice, is that for instance, in a patient who does have Barrett's, is differentiating between high-grade dysplasia and intramucosal carcinoma super, super essential? The answer is probably not, because both of them are going to undergo radiofrequency ablation. That being said, when you have invasion in the mucosa, and it is invasion in the upper GI, because those cases have a theoretical ability of metastasizing. So, especially if you have something like a signet ring morphology, or you have, a biopsy, which you can say, at least high grade or intramucosal, that should lead to them doing, some sort of ultrasound or CT guided staging of the cancer, so that they're actually seeing whether, there's lymph node involvement or how extensive the disease actually is. So the difference again is that if you remove an intramucosal polyp from the colon, 99.999% of the time you're cured, but you can't really say that about the upper gut. You can certainly recur, and you can certainly have metastasis somewhere in that area. That's not an uncommon thing.
So someone asked, which case do you do MMR testing?
So we do it on all of our colon cancers. So yeah, I mean, so occasionally we'll get a clinician asking us to do it on a Lynch polyp. I tried to talk them out of it, because in order to have loss of MMR testing, right? In Lynch syndrome, you have a germline mutation in one of your MMR proteins, or MSH3, or an EpCAM, gene methylation, right? Or no, that's not in Lynch though, but you can have rare gene mutations in EpCAM as well, which is in the promoter region of MSH2. But anyways, so in those polyps, I tend not to do MMR unless a clinician is really, gung ho about it, and sometimes it's easier to just do it and report it. And the reason for that is, in order to actually have loss of expression of the protein, you need a mutation in both alleles. And often when you're at the adenoma stage, you don't have a mutation. You haven't had that loss of heterozygosity yet. And as a result, you still get expression of that protein.
Okay.
But in our colon cancers, we do it in all, because especially in our rectal cancers, it makes a big difference in terms of treatment. Where these patients show exquisite response to checkpoint inhibitors, and they actually show, deficient mismatch repair patients actually show very poor response to conventional chemotherapy. So 5-FU FOLFOX treatment and such doesn't really carry that much efficacy in those cases, for a
Okay,
number
so
of reasons.
next question is there something like pseudo-invasive glands? Pseudo-invasive glands carry lamina propria along in the adenomas.
Yeah, that would be a pseudo-invasive gland, where if you see lamina propria, right? Because you shouldn't usually see lamina propria invading. So the one kicker, and the one really tricky thing is there is a variant of colon cancer called adenoma, like adenocarcinoma. A lot of those are deficient in mismatch repair. And those don't carry lamina propria, but they also usually don't produce a desmoplastic response. So you can see normal, I'm not normal, but you can see just like adenoma-like glands in the submucosa, and you're wondering what's going on. But again, it's disorganized. And when you have pseudo-invasion, again, you have that lobular look. And if you start seeing a haphazard look, that's proper invasion. And that might represent one of those. And we see these. I mean, they're not super rare, but you can occasionally get these adenoma, like adenocarcinomas, that can be exquisitely well differentiated. And again, they have no obvious desmoplastic response, so you're always a little nervous when you're pressing sign out on those buttons, but on those cases. But yeah, those are those cases.
The next question is, sometimes we get biopsy. Someone asked, sometimes we get biopsy from nodular mucosal lesions, but normal mucosa on microscopy. How to report?
Yeah. Yeah, we get those too. Yeah, so those, I mean, I guess it depends. So our endoscopists do a really nice job telling us if they think it's a submucosal process or something else, which if that's the case, then I say, look, the biopsy is predominantly mucosal, and, beneath it, there could be something benign like a leiomyoma or lipoma, or, maybe a soft tissue neoplasm or maybe a neuroendocrine tumor that they didn't biopsy. So I'll say that maybe they didn't hit the intended targeted tissue. But sometimes, in normal repair in the colon too, you can have, proliferative nodular-like lesions too, and it's probably normal. Or it could be like a lymphoid aggregate as well, which is normal. So I tend not to get myself too worked up about such cases. If I see something, I mention it, and I'll look at the endoscopy report to make sure it's nothing more serious. But if it's just nodular, I'll say, it's only mucosa and that's it.
So next question is, when do we say indefinite for dysplasia?
So that's more in the context of inflammatory bowel disease. So inflammatory bowel disease has very different molecular underpinnings compared to what conventional cancer is. So opposed to that beautiful stepwise approach we have in conventional dysplasia, in IBD, it's more a product of the inflammation, and the inflammation is generating free radicals in the colon, and that's leading to very significant changes in the chromosome. So rather than going from, low grade to high grade, you can go from low grade to cancer, or you can go from nothing to cancer, and it can be very wild. And the problem with it is that, when you have these really bad IBD cases, you can have a lot of inflammation and erosion and ulceration. So you can have these very reactive crypts that can look adenomatous, and they can look very convincingly adenomatous, but you don't see the surface. And it's arising in a background that's very inflamed, so you don't know what to do. Getting a P53 can be helpful, where if you have aberrant expression, it can make you go lean one way or the other. It shouldn't be your decision point, though. It should still always be morphology. So I think it's in those situations where you don't have an obvious surface involvement, but it looks dysplastic, is those situations where you say indefinite for dysplasia.
So next question is, how to differentiate inflammatory atypia from true dysplasia?
I don't know what intermediary atypia is, but I think for me, identifying, dysplasia in an adenoma, it's pretty much what I told you. The difference should be sharp, right? Going from normal to abnormal, it should be something where you can look at and you can say, when I'm going from, this part of the polyp, this part of the colon to this part of the colon, they look qualitatively different. It's not a gradient where you see like, really prominent atypia, intermediate atypia, mild atypia, no atypia. It should be pretty much like no, or like maybe some mild reactive changes to real atypia. And it should be that sharp distinction is how you're going to differentiate it most of the time. And sometimes, once in a blue moon, you'll get a case where it's, you're still concerned about dysplasia. And in those cases, you can do other things like look for apoptotic figures. You can look at the thickness of it. You can look at other things as well, too.
Okay. So someone asked, final impression of that first case you have described.
Oh, I would have said I would have called it invasive adenocarcinoma arising in a pedunculated polyp. I tend not to say what the polyp is that it's arising from, but it was an adenoma. So I would maybe say like arising from an adenoma. I would have kept it very sweet, short and sweet. In America, it's a very litigious environment. So the more you say, the more likely you're to get in trouble. So we keep our reports very simple.
Okay. So next question is, how to differentiate inflammatory polyp and solitary rectal ulcer syndrome?
So in a way, they're sort of the same spectrum of things. So in the past, solitary rectal ulcer syndrome used to be called cloacogenic polyps. And, they were essentially, fancy ways of saying prolapse polyps. And I suppose the main difference is you do see herniation of the smooth muscle into the surface, and you tend to see in true prolapse polyps probably more disorganization. And really, the underpinnings of a lot of inflammatory polyps too are probably prolapse, so there is overlap between them. I don't think they're entirely mutually exclusive.
Okay, thank you so much, sir.
Absolutely. Wonderful. I take it that's all we have right now? Excellent.
Yes,
Well,
sir.
it was an
Yes,
absolute
sir.
pleasure speaking to such a wonderful group, and I hope down the road we have more interactions to learn from each other.
Yes, sir.
Okay. Well, thank you all so much.
Thank you so much, sir.